Welcome to the Low-Carb MD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor. Welcome to the Low Carb MD podcast. We have a pretty special guest here, somebody who I've followed on social media for a bit, and he piqued my interest not only because he's a cardiologist, not only because he's empathetic to patients with obesity, not because he's probably has the most Ivy League names I've seen on his resume, but honestly what piqued my interest about Dr. Saenger was the fact that he's an ultra marathoner who's supportive of low carb diets. So I am very happy to have Dr. David Saenger here, and I'll just give a very brief intro. He's actually a New Yorker, so we may curse in this podcast, but that's going to be busy because New York
sounds good.
And we're going to interrupt a lot because New Yorkers interrupt a lot, but you guys will all be patient everywhere else in the world, I guess. So he started his undergraduate education at Harvard, brief stint with New York City tour guiding, which I want to hear a little bit about, but he ended up doing his pre-med at finishing off at Columbia, went to Stanford Medical School, did his internal medicine residency at Sinai, started working as an internal medicine doc and was called to do something more, went back, did his cardiology fellowship at Sinai, and now he is here with us. And somewhere along the way, he got inspired to do ultra marathons. So, Dr. David Saenger, it's a pleasure to have you here. Thank you for joining us.
Thank you. Thank you very much. Thank you. Yeah. So I live here in Eugene, Oregon, and I practice general invasive cardiology. So that means I do caths, and I put in pacemakers and do a lot of transesophageal echoes and read a lot of stress tests and echoes and cardiac CT and nuclear stress tests and so forth. So
we have a lot to talk about then.
Yeah, sure. Yeah.
Yeah. So
yeah.
So I'm curious. So how does a New Yorker end up practicing cardiology in Eugene, Oregon?
Good
Sorry.
question. Eugene, Oregon. Yeah. So I looked around for a place where it was a really good practice environment and where I could do a lot of outdoor activities year round, and has a good culture that's kind of more friendly to that kind of lifestyle. And this was just the best practice that I found, and that I wanted to go back to the West Coast, and I like the Northwest kind of vibe. I like the culture here, so I've been pretty happy. I've been here since 2004.
That's awesome. So help me understand. I always ask, what brought you to medicine? So you're a Westchester County kid. Okay.
That's right.
You're growing up, we probably grew up like maybe 10 miles apart, not even.
That's right.
What inspired you to start, start the healthcare journey? I mean, I'm always curious how people got to medicine.
That's a really good question. I think what I really like most is talking to people and hearing their stories, and kind of having that amazing opportunity we have as doctors for intimacy and connection with people. I think, the science part is cool, but that's kind of like after a while that you kind of get that, and it's not even that exciting. I mean, it's good, but I think what really sustains me in medicine, and what drew me to it was the chance to really connect with people and get that kind of like human interaction. And I think it's great. I'm still very happy in medicine. It's great.
You mentioned the human interaction. Well, it's funny you say that the science is easy. I have found that the more I learn, well, first of all, you have You have quite the illustrious career, I'd say that. So maybe you're much more versed in science than I am. But the more in science you go, the more into, now I've come on to, publish some articles myself and really face peer review and everything that comes with that.
Mhm.
What I've come to know is, and you tell me what you think, people ask me, for example, what was the magic in our employee wellness program that we did where we got, 38 pounds on average, weight loss.
Mhm.
And I told them it's patient empowerment,
Right.
and I really believe it's true, but like,
Yeah.
I think there's something to be said about the giant amount of science that I'm standing on. Do you know what I mean?
That's
I
true.
get to
Yeah.
empower patients based on my knowledge set, right? And now the conventional cardiologist, well, I shouldn't say that because most of cardiology has shifted to be more inclusive of multiple diet paradigms. So,
Mhm.
how would you compare, yourself and your dietary approach and how you empower patients to how you view sort of the rest of cardio, basically all of cardiology? You know,
Yeah.
there's
That's
got to be a
interesting.
disconnect. Am I off? Are you empowering your patients better? Are they not empowering patients enough? Is it just different? I mean,
Yeah. I think the lens of talking about patient empowerment is really, it's a great way to think about it. That's a really good point. I think about it. I mean, if you want to talk about diet and stuff, I think where I got started was I started asking patients questions and listening to them more. I realized the emptiness of just telling them, you need to do this and you need to do that, and instead of being like prescriptive, I got more interested in listening. I think that's where it starts, like seeing where they're coming from, what their what their reality is like, and what's going on, how did they get to where they are, and where can we meet each other to find some sort of path forward in terms of dealing with behavioral change, and I think I mean that's where I learned a lot from you. I think so. I think I guess comparing to other cardiologists, that's an interesting point. I mean, I think what
I mean, you go to these conferences and
yeah.
you meet colleagues, and I
Yeah.
feel like keto is a four-letter word that
Hmm.
to some degree, and most of the cardiology field, and this isn't a criticism, is plant forward. Whether it's right or wrong, I'm not
Yeah.
sure. And
Yeah.
so, if you're a how do you navigate sort of what the convention is, and where the science is in your interpretation of the science, and how you empower those
Mhm.
patients? I'm guessing there's a disconnect because here you are, a cardiologist, few and far
Mhm.
between, who is supportive of low carb.
Mhm. Yeah, so what I do, I mean, the lens I take is talk about metabolism, not calories. I mean, that's the first thing. I always start like, let's not talk about calories, because it doesn't work. I mean, and I learned that from talking to patients. That's where I got started. Was I talked about, well, does it work for you to just count your calories? I mean, is that and it never works, right? Nobody has ever really lost weight by counting calories. So I say, okay, what does work? How can we, what's a good way to think about it? Well, let's talk about metabolism. And what is good, what is a good way to think about metabolism? And I start right with, I mean, I gotta acknowledge Gary Taubes. I mean, I think this all started reading Gary Taubes's books, and Jason Fung reading his book. And I mean, I just started with that, and then I kind of like, I mean, when I'm talking to patients, I say, look, what works for your metabolism? How can we fix metabolism? And if you work on that, it's kind of like, the metaphor I always tell patients is that, like, it's like the calories are like the waves on the surface of the ocean. They might make you wet, they might splash you, but they're not really going to move a lot of water. That's not where the water really moves. The water moves in the ocean current, and the deep ocean current is the metabolism. And that's what really drives the movement. how do you fix your metabolism? And the only, you have to admit that there's, whatever, people say about being plant forward, or, talk about whole grains or whatever, they can't deny that, insulin is real, right? I mean, we know as doctors that insulin actually is a hormone. It actually has a lot of powerful effects. And if you have a low level of insulin, it's going to be a lot easier. And if your insulin levels are high, it's going to be a lot harder. And that's kind of the way I'm starting the discussion with patients. So yeah, I mean, and the thing that keeps connecting me back is to my personal life with ultra running. I've realized that, it really works. What works for ultra running works for everything else. It's just another lens or another stage to see the benefits of having a better metabolism. If your metabolism is, if you're what they call, I always introduce the concept of being fat adapted to patients. If you're fat adapted, meaning that you're using fat as your fuel source, you can go a lot longer. You're not going to get hungry, and you're going to feel a lot better, and you're going to have a lot more energy. And you can do a lot more, than if you're stopping to have sugar all the time. So, and in the end, life is just so much easier. So that's kind of the way that's the framework I use. I try to talk about that.
So I want to step back, because you mentioned, I mean, clearly a man of the amount of it. I don't think there's a person on this podcast we've had with more sort of Ivy League names in their education career, right? So clearly you're a science-based proponent, and yet, we're here talking about two books. You mentioned Gary Taubes, and you mentioned Dr. Jason Fung, which, I'm huge fans like you, but historically, if you look at academic scientists, they've been very critical of both Gary Taubes and Jason Fung.
Yeah,
and so
that's a good point.
I'm having a hard time. Help me understand. I'm having a hard time reconciling, a man of your academic prowess, right? And, particularly being, sort of at the, let's just say, the pinnacle of medicine, right? How is it that, where does it shift from science to what actually works in real life? Because I see that mental pivot you've done, and I'm trying, maybe I'm supposing it's there, but how do you go from, I'm going to, how do you go from, I'm reading, Harrison's back cover to cover, which is the internal medicine textbook, to here's Gary Taubes, and here's, obesity code and diabetes code. So how does that personal switch happen? And how do you assimilate this with our baseline education? Because I'll tell you, there's a big disconnect. What we were taught was the energy balance theory, essentially.
Right.
I mean, we may have had some exposure to glycemic index, throughout your career, I'm imagining, but the fundamental basis of our education, I'm assuming, was there. So how does this transition happen? How does it, how do you get there?
It's a really interesting one. I think for me personally, I think where I got there was that I approached medicine in general from the beginning with a kind of more critical eye. I mean, I went into medicine a little late, right? I was an English major, and I didn't do any pre-med. And then I came in at after college thinking, I want to, wow, this medicine thing seems really cool. But I approached it as an outsider from the beginning. And I think I had a little bit more of a outsider's kind of critical vantage point to look at medical science, and to, I think there's a lot of it that's great. I mean, of course, as you said earlier, I mean, we all stand on the shoulders of giants. I mean, you have to have respect for science and what it's brought us. But then there's also an element of groupthink that occurs in almost any culture, including medical culture. And there's an element of people get into a culture, and they think that they kind of have a thought pattern, and the energy balance model kind of, it sort of makes sense on one level. And so I can see why And it also, like, get back to what you said about patient empowerment. The energy balance, what I always tell patients is that the energy balance model is blaming the victim, right? I mean, if you tell somebody that, you got fat because you ate too much, that's blaming them. That's like shaming them, and it's judging them. And that is a very easy paradigm. It's very easy to do that when you're the doctor. But if you want to shift over to empowering the patients, you have to have an attitude of a little bit more of like, look, this is something you can take control of, and here's the tool. And you don't have to just be a slave to energy balance and to just calories in, calories out. And you didn't get this way just by being lazy and gluttonous. And in fact, it's because your metabolism's messed up. So, and here are the tools you have to fix it. So that's kind of the way I think about it. And I think, I guess what you're asking is, how did I get here? I think I had enough of an independent way of thinking from the beginning that I could see that, well, this is one case where, the emperor has no clothes, right? I mean, this whole idea of the eat everything in moderation and that whole paradigm, it never really made that much sense when you looked at it more critically. And then I have to say, I was also guided by evolution and the paleo kind of thing. That really appealed to me. If you think about it, I mean, if you look at our ancestors and where did humans come from? If you admit that we're originally hunter-gatherers, then how can you explain eating bananas in January? How can you explain eating whole grains? Where does that come from? What are whole grains anyway? That whole way of thinking things a little bit more critically. I think
I sense that very nihilistic kind of stint, like sort of, don't. You mentioned being an outsider your entire career, right?
Yeah.
Is that what you
so
see?
Yeah, I think I'm comfortable being kind of a bit of a contrarian to some extent. So I don't mind that. It comes pretty naturally.
Okay, so I mean, that could be challenging though. So how do you be a contrarian? How do you be a quote unquote critical thinker? Somebody who's trying to think outside of the box and make it through, 4 years of internal medicine at Sinai, going off the summit, going to Sinai for cardiology, or how do you?
I think you have to be a contrarian about some things and not about everything.
So you're political then, I guess.
Yeah, so I'm not a contrarian about absolutely everything. You have to sometimes accept the conventional wisdom is right sometimes. It's just not right every time. So
Got it. Okay, so you're thinking outside the box, and to some degree you're pondering, you're theorizing, you're saying, wait a second, I don't see the current system working effectively, and you're looking at your patients and maybe they just struggle to count calories, and you're thinking evolutionarily. So, and I've seen this, this concept, and it comes with flaws, but I guess you're just pondering, you're just thinking like, wait a second, if we didn't always have supermarkets, how did this happen before?
Right, exactly.
And it's a, this is, I guess, where the establishment mindset of energy balance would say, well, that's a trope. Just because things didn't happen evolutionary doesn't mean it's optimal, right?
That's true.
So okay, but here you are. That's where you're. And I, by the way, I 100% agree with you. I'm just sort of theorizing and being a little.
No, yeah.
So
I think it's really interesting.
So you're questioning this, and you're thinking, well, wait a second, how did we used to eat? And then, I mean, how do you go from Harrison's to good calories, bad calories?
Yeah. Well, I mean, I think Nina Teicholz's book also, that really changed my life. That was an amazing book. Basically, she just explains how this whole Mediterranean diet thing is a total fraud. And she goes into all the details about the how they how the fraud happened. And I mean, it's like a detective story. I mean, that was amazing. That really changed my life. It made me see a lot more critically, like how people can, scientists are human. I mean, I think that's the point. You can, Ansel Keys, he's a human being just like anybody else, and he can have his own biases, and that's where this whole Mediterranean diet thing came from. And then people just took off with it and just started doing like very, what I would call lazy thinking, just kind of like, oh yeah, okay, if the Harvard School of Public Health says that we should have a plant-based diet, then I guess it must be right, and they don't even pay attention to what's actually happening to patients. And I mean, and for me, what I learned so much from doing ultra running. I mean, I came from being a once a year marathoner, getting injured all the time, and having to take off running because I kept getting hurt. And then I realized that when I went into low carb and went really low carb and started intermittent fasting, I realized that I could run a lot farther and not be hungry and not be tired. And I stopped getting hurt. I stopped getting injured. And it was amazing. And I started getting faster and faster. So, and I started, I mean, it just made things so much easier for me. And I'm just realizing, wow, you can be fat. And also I think there's a mental benefit. I mean, I got to say, that's the other thing that a lot of people, you come to low carb for weight loss, but you stay because of the mental health. I mean, I think that's really what people, it's really true.
Give me about 6 months and we'll have that published. So, so I want to step back, because I think both of us would probably pride ourselves in being a science-based and evidence-based, and going through our board certifications, and yet both of us are here influenced by the way, Nina Teicholz's book Big Fat Surprise, I think, is just an absolute must read.
Absolutely.
And Good Calorie, Bad Calorie. So we've mentioned these books, and Dr. Jason Fung also. But so now we're being influenced by diet books, and we're being influenced by our own personal stories, right? And we're being influenced by our clinical observations.
Yeah, right.
So, and I've fallen, I'm like, I could mirror that. So here you are, you're reading these books, and how long ago was that? And you're noticing, you're noticing your body is changing. You're noticing you're not hungry. But when is that happening in your career?
About 15 years ago or so, maybe 10, 15 years ago, I realized that like I was just tired of getting hurt all the time, and tired of being tired, and having to stop for lunch and all this. I really like what you said, like we should normalize not, fasting during the day. We should normalize not, being able to not eat until afternoon. It's totally, but yeah, no, for me, I gradually, over a course of about a year or two, went into, I just kept trying it and kept realizing that it was really working.
Like a paleo approach? Did you start paleo?
I think you start with paleo, right? Yeah, I start like a lot of people. I started with paleo and got rid of sugar, and then I realized it really, really works. I mean, it's amazing. And then I try after paleo, then try fasting, then try going really low carb, and and see what happens, see what works. You have to just kind of experiment with it personally, but I just saw that the personal benefit is so phenomenal, and the mental benefits are just so awesome. I mean, we work as doctors, it's stressful, right? I mean, it can be really stressful, and the energy burden of being a full-time physician is hard. I mean, it's a lot of work. It's very stressful, and anything that gives you the kind of power to do it and not feel burnt out and not feel tired is incredibly powerful. And that's where I tried to share that with patients and with colleagues, and it's gone really well.
So it sounds like you were a lifelong runner. Is that accurate?
Yeah, but not right, but not quite a lot more casual and a lot more shorter distance. Not, a marathon would be the max I would even think about. And
That's already like more than 99% of people
that's true.
listening. So,
It's true.
so walk me through. You're at Harvard, okay, as a 18, 19 something year old, and then you go to
Hmm.
Stanford, and then you're at Sinai. So you're running back then maybe 20 miles a week.
Yeah, something like that. Exactly.
Okay, and
And
then you
getting hurt, often getting hurt and having to take time off of running.
and that's like an ankle injury or a pulled
Right. The
hamstring,
usual.
something like
Right.
that. Okay.
Right. Exactly.
And then you go off to work for Summit Health, which is interesting. This is what, how long ago were you at Summit? This is
Oh, that
15
was in
years ago?
2000. Yeah, that was right after I finished residency, which was in 2000 for a year. I did that. The primary care is great. I mean, there's a lot of good
Interesting.
things of primary care. I have nothing bad to say about it, but I realized that it just wasn't for me. I mean, it was just too, like, they really make, as you've said before, that the way that they churn you through patients, you don't get enough time to talk to them. It's hard. And I also really remember that I really liked cardiology. I was happy, so that's how I went back.
Got it. Summit Health, just interestingly enough, in those past 15 years or so since you were there, they just sold themselves to Walgreens.
Wow.
Right. So Summit Health sold themselves to Walgreens and making pharmacies the third largest employer of physicians.
Wow.
Isn't that interesting?
Wow.
Right? You want to
That
know who
is,
the
yeah.
first largest employer is?
I'm gonna guess, is it the VA or?
Insurance companies.
Oh, wow.
You want to know who's
Wow.
the second largest employer of physicians? You're going to be
Kaiser? No, I
venture,
wonder who.
as a group, venture capital firms.
Really? Wow.
The fourth biggest is hospital systems.
Oh, okay. So that's me
Hospital
now.
systems.
I work for a hospital system. Yeah.
Yeah. So you were working you were working for what now is Walgreens.
That's funny. That's
Yeah.
wild. That's
Yeah.
wild.
So okay, so you're getting injured and then you just find as you go paleo and then as you go lower in carbs that you feel better and better. And I'm guessing at some point you personally feel better, you see it in your patients, and this transitioning is occurring. Good calories, bad calories is, it's been about 15 years since it was
Yeah.
released, and Nina Teicholz book about 10 years ago.
Yeah.
So I'm guessing your nutritional message changes over that time to your patients. So
Yeah.
where was it, back at Summit Health, and where is it
No.
now?
Yeah. So yeah, back at Summit Health or something like that, or when I got started, it was all about, energy balance. And it was kind of like, what I like to say is the old way of thinking about weight and diet is kind of blaming the victim. And I realized the emptiness of that. I realized that the fact it's just so not compassionate. It's so hard for people to, I mean, I could see myself talking to patients and saying, like, you just need to eat less. I mean, what kind of crap is that, right? I mean, that doesn't help people at all. You didn't need to go to the doctor to hear a doctor tell you to shame you and tell you to eat less and move more. I mean, it's just so stupid and it's so unhelpful to patients. And I basically heard myself saying that and said, what am I doing? How is that working for people? That's kind of where I got started. And
So what does your nutritional message sound like now?
I think at the moment I'm a little bit more. I'm influenced by Ted Naiman. Also, I really, really like his book and his message. He's great. He's a little bit more protein focused, which I think is really probably good. I say to start with protein. That you really need. I mean, that's the only thing you really need, right? You need protein to keep the to repair things and to make you stronger and to keep your muscle mass and so if you I mentioned that and I say, look, what you don't need is carbs. The amount of carbs you need any day to survive is exactly 0. So I mean, you're not going to get to 0, but I say you can get pretty darn close. And just try to experiment with it and see what happens. If you can try, I mean, I tell people to try to like just start with the easy stuff, right? Just get rid of the sugar, get rid of the baked goods, get rid of the oatmeal, the cereal, et cetera, all that stuff, anything with grain or sugar, and then see how you feel. And then if you're starting to feel better and it's looking like you can do this, then try getting rid of of other sources of carbohydrate. The only carbohydrate I tell people that's okay is green vegetables. That's fine, but then and don't be afraid of saturated fat or meat and all that's fine. I mean, people are often really shocked when I say that. I'm like, look, what's the evidence about saturated fat being bad for you? Let's take a look at that. Where does that come from? I mean, how good is that evidence? And then let's look at the PURE trial, right? That was a huge trial, like what, 200 and something thousand patients, prospective, and it showed saturated fat. The more you ate, the longer you lived, right? So is there really anything wrong with red meat in that situation? And I would say, look, I mean, you have to talk to people based on their value system. If you're a vegetarian for moral reasons, totally okay. I'm not going to argue about that. If you're a vegetarian for the environment, look, I get it. It's complicated, but I'm not here to talk about the environment. It's complicated, but look, let's just try to move beyond the energy balance model and look at how you can get protein and how you can be healthy and what makes you feel good. I mean, what makes you able to sustain yourself, and how can you exercise? I mean, it's the other thing is we tell people to exercise, right? We tell patients to exercise, but we don't give them the tools. I mean, if you're, as you've said so powerfully, like, telling a really obese patient who's eating a terrible diet to get out and go to the gym is just cruel, and it's not going to work. It's not going to get them anywhere. What you want to do is try to tell them to, how can try to lead them forward into a more healthy lifestyle by focusing on improving their metabolism, and then get moving, but not be trying to, like, you're not going to burn off those calories, right? I mean, that's something I hear patients say all the time, and you probably heard it too. Patient comes in and they're overweight, and they say, well, if I could just get to the gym, if I can just fix my knee or whatever, then I'll get rid of all this weight. And I always say, no, that's not the right way to think about it. It's not. I mean, look, exercise is fantastic, but you're not going to burn off 100 pounds in the gym. It's just not going to happen.
But you must be such an inspiration for your patients. They must know that you're an ultra marathon.
Oh, thanks.
You know what I mean? Like they
Yeah.
must really, that's got to be an inspiration for them to see, you're out there running 100 miles, not eating granola bars and gels,
right.
and
Right.
Well, actually,
right.
I'm interested. How do you fuel when you're training versus how do you fuel when you're out there on a 100-mile run? Because I'm guessing it's different. I'm guessing you're a train low, run medium, or
that's
medium.
About right.
Yeah.
I have a huge my guru for that would be Zach Bitter. I'm a huge. I think he's amazing. He's talked a lot about how to do that. So I think when you're training, actually, it's a lot. It's really important to focus on that fat adaptation. So you want to be using fat as your fuel source, and if you're fat adapted, if you're not needing to have to carry like a bunch of gels to do a run, then it's a lot easier. As long as you have water and electrolytes, you can just keep going. And the key, I think, is that zone 2, right? You want to be in that moderate amount of exertion, that heart rate that's about what do they say, like about 70% of maximum. So just not super hard. You're not like huffing and puffing, but you're going, and you can keep that zone 2 going for a long time. And for me, for training, that's what I do. I keep that zone 2 mostly. I mean, occasionally.
What's your carb count at? What do you?
I
Yeah.
don't have any. No, I run fasted every time.
No, I mean
I
like in a given week, like if you had to peg
oh
your grams of
oh wow.
non-fiber carbs, so what do you think that'd be?
It's really, really low. I don't know. I mean, I don't, geez, I don't know.
100, 200, 300,
I hate
500?
counting grams. That's my whole thing. I talk to patients like, they go see a nutritionist and they tell them to like have so many so and so grams of carbs.
I'm
And
just
I
curious,
don't, it's
like
impossible. It's so
what does your
hard to
meal,
count.
what does a typical meal look like for cardiologist David Saenger? Yeah.
I'll have whatever family dinner. So I'm gonna have meat and some veggies and some I'm not gonna put rice on the side. I'm not gonna have bread on the side or anything like that. And
So a
so
plate
I
is
don't
like half protein, half vegetable.
yeah, like that. Yeah, pretty much. Yeah.
Okay. And how often do you eat?
Oh, so during I basically just have one meal a day. But then if I'm really worried, like if I'm doing really high training loads, like if I'm training for a 100 miler or a hard 100K like I was doing recently, I'll have because I'm going to be running like maybe 8 miles or 10 miles in the morning, and then I think I need protein, right? So
Yep.
in that case, I'm going to be I might have a whey protein shake or something at lunch, or maybe a can of sardines at lunch or something like that. So, but otherwise I'll be doing the one meal a day pretty much.
So like your
So
baseline is one meal of protein and veg, and then you
yeah,
basically add or subtract based on your exercise load.
exactly. Yeah, exactly. Yeah. And
Right.
then if I add or subtract, it's going to be protein. If I'm in a race, it's different. If I'm running a race, then I'll have some gels because they're right there at the aid stations, and it's easy, and it more of almost like a mental boost, to break the monotony of racing. I don't really need it exactly, but it is, I think, a short-term performance enhancer, especially if you're going into that zone 5 area. I think carbs do provide a boost there.
Or over
Um,
2 hours, I would say. If you're
yeah,
doing,
right.
exercise over 2 hours, I'd say that's the only need, like 2 hours in a day. So if you're a listener, the data says under 30 minutes, definitely no need. Under an hour, questionable need,
Right.
and then over
Right.
2 hours, probably, if I was doing a race that's 2 hours or longer, I would probably have some sort of carbohydrate, and this is a
Exactly.
low carb
Sure.
MD guy saying that.
Yeah,
So I'm just curious. So you train low. It sounds like your OMAD, protein
pretty
veg,
much.
you know,
Yeah.
um,
Yeah.
and then
Yeah, OMAD is it's great. I gotta say that. I mean, that's been a huge game changer for work. I mean, like I can be in the cath lab and doing tough procedures, and I'm not hungry. I mean, it's awesome. I mean, I just keep going. I'm fat adapted. I look at myself like, well, I mean, if I run, I can be running this far and not run into problems. I can certainly be in the cath lab and not be having problems. So and it just makes things so much easier. I don't have to stop and worry about where am I going to get lunch. I mean, it's great.
so so it sounds like your own personal, kind of life has changed, and
Yeah,
the way you advocate for your patients has changed.
yeah,
Um, and it sounds like a shift occurred at some point in the last 15 years where you went to
yep,
whatever works. It was like not really the
exactly.
mantra that we were exactly taught, but not
Yeah,
complete disengagement from that, but more of what works for the person in front of me.
exactly. I mean, I got to say one thing that has been really inspiring is my patients who have had amazing improvement in their health. Like you've talked about this, like de-prescribing medicine. I mean, as a cardiologist, that is the biggest thrill I get is when I have a patient who comes back and they're like, you know what, doc, I cut out the carbs and I don't need that blood pressure medicine anymore. And I can stop that glipizide and I can stop that. I mean, it's just amazing. And like I have patients with AFib and we're like, we don't need the flecainide anymore because I'm not having AFib because I lost 20 pounds. I mean,
Oh,
it's
I want to talk
amazing.
about this. So AFib is a question we get all the time, and I'm glad you bring
Yeah,
it
I'd love to
up.
talk about
You know,
AFib. Yeah.
so
Yeah.
so the data's pretty clear, and you tell me 90% of, I've seen data at least to suggest 90% of AFib can be resolved, right? Can be resolved with weight loss. True?
Absolutely.
True.
I see it all the time. I've seen it in my own practice so many times. And with elderly people, I mean, people need to have a lot more respect for patients. I mean, so many doctors, they have low expectations of their patients. And I think that's really, that needs to stop. I mean, we need to tell people the truth and expect that they can implement behavioral change no matter how old they are. Like I have an 80-year-old patient I just saw last week, and he's like, he used to be having AFib almost every day, and he went low carb, and now he gets AFib like once a year. And it, instead of lasting for hours, it lasts for 2 minutes. And yeah, I'm not going to stop his anticoagulation, but certainly we can back off on the antiarrhythmics and so forth. It's amazing. I mean, I've seen tons of that over and over again.
And can you talk a little bit about, so I know in very resistant AFib with RVR, very resistant AFib and RVR in the hospital. I remember as a resident, we'd certainly rate control. Sometimes we'd try cardioversion. If all of that, we're waiting for cardioversion, which means kind of zapping somebody into a regular rhythm. Yeah. If we really couldn't use meds anymore, or didn't want, or we, maybe the blood pressure didn't tolerate it, we would often give magnesium. We would give a magnesium drip.
That's right.
And I've often wondered, in AFib patients, should we be supplementing with magnesium? Should we be supplementing?
Yeah, we should. Yeah, magnesium is super underused. Yeah, I'm a huge fan of magnesium. I take magnesium, and I'm like known in the practice as being the magnesium doc. I'm like crazy about magnesium. I give it to everybody. So it's so harmless, right? And it definitely helps. If you're in India and you come into a hospital with AFib, the first thing they do is they give you magnesium. So yeah, I mean, maybe it's not as powerful as as amiodarone or whatever, but it's a hell of a lot less toxic. And sure. So yeah, we should be using a lot more magnesium.
So,
absolutely.
And let's go further into AFib. So I forgot the average listener may not even know what AFib is. So I'll just give a second to tell them, or, well, actually, we have a brilliant cardiologist here. Why don't you tell the listener what atrial fibrillation is? Go ahead, give us the 1 minute, the 30 seconds.
AFib is a chaotic, rapid rhythm that originating in the atrium, so it's part of the heart, and it's the top chambers of the heart are in control. And instead of just beating regularly, they're beating very fast in the chaotic way. They're kind of like having a seizure. They're shaking. And that makes the lower chambers, the ventricles, beat fast and beat in an irregular rhythm, and will therefore often reduce cardiac output and put you at risk of a stroke. So that's the easiest way to say what AFib is.
Yeah, so it's an irregular rhythm, and one of the things that it does is it can double or triple your risk of a stroke, and depending on your baseline kind of health status, a doctor may consider aspirin or a more potent blood thinner.
Correct.
And then that deals with the side effect of AFib, which is the stroke that you mentioned. But then we try to figure out how to keep the heart sort of calm and settled. And where does I know it's gone back and forth, whether we just slow the heart down, whether we put it back into a good rhythm, and this constant back and forth. Well, before it was just the rhythm was good, and then it was just the rate, and now it's maybe a little bit of both. So where have you landed,
Yeah, so I think it depends. I think there's some patients who, you're talking about the difference between rate control versus rhythm control. So the first thing you want to do is control the rate. That's the basic, is you don't want to be going 150 beats per minute all the time. That's not good for your heart. And it's not good for your cardiac output. You're not going to feel good. So you control the rate, and then controlling the rhythm is a little bit more complicated. Not everybody necessarily will do better with rhythm control, but you want to, and they've done a lot of studies showing that rhythm control probably doesn't change the long-term outcome for most people most of the time. So, but it will improve symptoms. It makes a big difference in terms of symptoms for most people. So the way to approach it is to give everyone a chance at rhythm control. That's an easy way to say it. It's like everybody deserves one shot at going back into sinus rhythm, and then see what happens. I mean, I have people who I put them in sinus rhythm and they say, I feel exactly the same. I don't feel any different. So in that case, fine, we're not going to do this again. We'll leave you in AFib and we'll just control the rate. But if they are like, they're people that they were skeptical, they didn't necessarily know that they wanted to go back into rhythm, but you put them back into rhythm, they're like, oh my gosh, I feel so much better. Then you're going to keep them in AFib. And there are people that they come into AFib and you see them initially and they have reduced LV function, and you put them back in sinus rhythm, the LV function goes back to normal. I had a patient just like that recently.
So what you mean by LV function, I'm going to translate how effective the heart pumps, right? So
correct, right. Yeah. Your heart pumping function, which is really important in cardiology. We like to pay attention to that, to the left ventricular ejection fraction, or how well the heart is working, and that can be so if you get people into sinus rhythm, a lot of people, their heart function is better. So that's a good reason.
We talked about de-prescription, so I'm gonna probe around de-prescription here.
Sure.
You have a patient who came to you, say a 50-year-old male or female, and they went to the world's best metabolic clinic, and they lost hundreds of pounds. Mm-hmm. Okay, so they lost hundreds of pounds. So they had atrial fibrillation, maybe they had sleep apnea, and maybe they were a metabolic mess, but they've lost 150 pounds, and it's now been years that they haven't felt symptoms of it. You've even done several event monitors, let's say a Zio patch on their heart, and every single time you've looked at it, they've been in normal sinus rhythm the entire time. So this is now maybe a total of 9 weeks of normal sinus rhythm, right? And they've lost weight and they're exercising and they feel.
So would you stop the anticoagulation? That's what you're asking.
No. So the question is does the risk profile change at any point? And how do you determine who's ready to come off and who we should probably keep on? And I got to be honest, my preference is usually to keep aspirin, but sometimes I think to myself, so just so the listener knows, there's potent blood thinners, which have let's say a under 1% chance of a severe bleed. Aspirin, I think, is right around the same, maybe 0.5.
It's around the same. Yeah,
to 1, right? Depending on, and then, there's always even off of those, you have like a 0.1% chance of having a severe bleed. So the reason why you'd want to de-prescribe is you'd consider at some point, if the risk drops far enough with major lifestyle change, what do we do? So help me understand. I'm a boring, internal medicine guy. What do I do? What do I do, Doc?
So I think you can always reassess the risk, right? I mean, if they've lost all that weight, then you can maybe check the patient no longer has hypertension or diabetes, right? You can cure hypertension and cure diabetes with dietary change. I've seen that happen, right? So then their risk of stroke has gone down, and then the need for anticoagulation can be reassessed.
A hard call, huh?
Yeah, it's a hard call. And I believe in shared decision making, right? I mean, you tell the patient what we're doing and where the risks and benefits are, and you let people decide. I mean, I have people who are just, you give them it's an informed decision.
Can I give you my apprehension on why I wouldn't consider potentially taking them off aspirin or anticoagulation?
Yeah, sure.
You tell me if I'm wrong. I kind of view it, if that atrium is stretched, can we shrink it? So the problem, the listener. So for the listener, we're talking about this area in the heart where the blood pools and would cause a stroke. And if that area is sort of fluffy, can we make it less fluffy? I view it like a rubber band, once it gets overstretched, I wonder if so I don't know. I'm nervous about.
Me too. Yeah.
I'm nervous about.
I don't. I mean, and the new anticoagulants are so much better than warfarin, and the risk of bleeding is so much less. It's so much easier. I think that's really been a huge gift to cardiology. So, and to making this easier for patients. So, everyone wants to stop Coumadin, but I think people are a lot easier about continuing one of the new anticoagulants. I just wish they were cheaper for patients, but that's another story, I guess. But I think, yeah.
Can I also give another side of it? Technology has outpaced cardiology. So now we have basically 24/7 AFib monitors that can go on somebody's hand.
Exactly.
Right.
Yeah.
So
I see that all the time.
So I wonder, so now let's say somebody has had years of no AFib and they track it regularly. And now we have these easy to use, like nearly like 3-week long, monitors that are just easy to put on. And so our ability to surveil AFib has outpaced our pharmacologic approach.
Exactly.
That's the other part where I say, well, maybe we can take people off of medication. This is the beauty of telemedicine. It is changed. It has changed our management of AFib, but I don't think the data has changed. Even though it makes sense to you and me, well, I have patients right now that have Holters in their home that I can monitor. I have a EKG, I can monitor it in real time.
Right. It's amazing. Yeah.
So, and I have these event monitors where I could see their heart rate for weeks. And I have, I can connect to their Apple Health Watch. And I can, so that could give somebody ease to de-prescribe, no?
I agree. Yeah. Yeah, we're doing that now. I mean, I think that's the future. I mean, that's like what Eric Topol talks about in his book about making patients more powerful, empowering. What is his book called? The Patient Will See You Now. The patient empowerment, and that's kind of the wave of the future. That's like with CGMs, right? It's kind of the same thing. It's the patients taking charge of their own data, and the patient-doctor relationship being more about like giving informed, shared decision making, and less about like just telling people what to do. So,
well, it's also surveillance. Like, so the amount of data coming into a doc. I mean, just think about that for a second.
That's true.
Before we had to assume that once you have AFib and you don't go back, that it's always there. But now, we know that weight loss can reverse 90% of symptoms and potentially the AFib burden. And we know that we can track it, which to me excites me about de-prescription.
I agree. Totally. Yeah, I think it's changing the paradigm of medicine to a large extent, which is great. I mean, either you're going to like that and get on board, or you're going to resist it, and then you're going to be frustrated. So, I mean, I'm happy with it. It's fine.
Do you find that, like, in your, you probably converse with cardiologists more than I do. Are they accepting of? I mean, they must be accepting of technology.
Yeah. I mean, that's a good question. With technology, I think they are. I think we're slowly getting used to it. I think there was some resistance at first, but I think we're getting more comfortable with it, because we have to go with where the things are. Sure.
So I want to come back to one last point before I know, we're coming on an hour, and I know your time is valuable, and you're out on the East Coast, and I'm sorry, you're on the West Coast, bright and early. You probably woke up your whole family to be here. So my I have two areas I'd like to explore. What should an average listener know about cardiovascular imaging? And for prevention.
Okay.
We've talked a lot about CACs. We've had Arthur Agustin on. We've had a lot of people talk about the utility of, coronary CTAs and CACs. I'm a big supporter of non-interventional imaging, like carotid intima media thickness. So where do you think, the role for imaging is for cardiac prevention as it relates to, other things that cardiologists track now, which is pretty much lipids and inflammation?
Right. So I think imaging is really powerful. I I'm a huge believer in getting a coronary calcium score for people. I'm not such a fan. I used to like intimal medial thickness, but I think it's too operator dependent, and it's too unreliable now, unfortunately. And the amount of radiation with a calcium score is pretty darn low. It's in the range of a mammogram or a chest X-ray now, so it's pretty low. I think that's okay. So I think, and the cost burden. I mean, there is a cost issue with CACs, but I think the cost is not that overwhelming, and I think it's
$50.
it's better. Yeah, exactly. So yeah, just look at the I mean, the whole idea is we don't really understand why some patients will have high cholesterol and have normal coronaries, and some patients will have low cholesterol and have bad coronary artery disease. I mean, I think we don't understand all the risk factors, and so getting a calcium score,
and insulin resistance aren't enough.
exactly right. There's so many things going on. Exactly. So I'm a big believer in getting a coronary calcium scan if you really want to optimize prevention. I think it's great. I offer it to almost everybody. I mean, not everybody wants it, but I offer it to people. Sure.
Yeah, and another comment I put out, we're I'm a big believer in, believe it or not, I'm a big believer in genetic testing. If you're a low carb proponent, I'm sure you've run into higher cholesterol levels. So we've in practicing evidence-based medicine, we've pursued genetic testing in anybody with an LDL over 190.
Okay.
And we're seeing some pretty clear patterns in people with a high LDL. And, we started publishing on these. There'll be further studies coming out, and we'll probably publish more. And what do you think about, the role of gene testing in people with, high LDLs on a low carbohydrate diet? What do you think about, people who have a baseline normal cholesterol, and when they go low carb, their cholesterol increases and potentially above where the AHA, ACC are comfortable with, which is that 190 mark.
Right.
How do you approach that patient? Because they're coming to me now, right?
Yeah.
We're doing CACs, genetic testing, and, and sometimes carbohydrate reintroduction, sometimes pharmacotherapy. How do you approach? I mean, if you're a low carb advocate, I'm guessing you're seeing this enough to.
Yeah, I do see some of it. Yeah, this is what you've published on, is the whole lean mass hyper-responder thing, which I congratulate you on that. That was great. So
it was called an embarrassment, just so you know.
No, I thought it was awesome.
Yeah, so Thomas Dayspring said it's quote unquote embarrassing. So
why? I thought it's real. I mean, yeah.
I don't know, but anyway, but okay. I appreciate the compliment. Thank you.
Yeah, no, well, first of all, I check ApoB, not LDL, right? I mean, I've been, I'm hip to getting ApoB level, which is probably more informative because it encompasses the particle size, which is more useful than just looking at the LDL concentration. So, and if their ApoB level is high, then I would go ahead and treat it. I sort of focus on the phenotype ahead of the genotype, right? I mean, the genotype tells you why things are, but I want to know where things are right now, where the action is right now. And for that, I'm looking at the ApoB, and I'm looking at the calcium score, and trying to get the ApoB as low as possible if they have a high calcium score, especially. And checking it also, don't forget lipoprotein little a. If lipoprotein little a is elevated, that's mostly a genetic thing. You're not having to check the gene, though. You can just look at the phenotype. You can just look at the LP little a level. And if they have an elevated LP little a, that's really important. So that's kind of my approach. I haven't done a lot of genetic testing, but maybe I should. I mean, maybe I need to read up on it some more, but I mean, it's
a controversial. If you look at polygenetic risk scores, they don't really change outcomes, but I think one of the things that I'm faced with is, you get a patient who's somewhere between 40 to 55, where you'd expect a calcium score to be 0, and you get that calcium score in the face of a high number that's, one time elevated. We routinely check lipoprotein A in every patient, ApoB in every patient, and an NMR panel in every patient. And the insurance companies hate us, but you know what? Screw them.
Right.
But and what I've seen is, many people with high cholesterols on a low carb diet come in actually lower, and many people, and it's more related to their degree of carbohydrate restriction. We've also seen lipoprotein A decrease, which
that's not supposed to happen. Wow.
Yeah, well, so David Ludwig showed that in his 5-month controlled study, and we've seen exact response. So he noted a 10 to 15% drop, and in our clinic we have a 10 to 15% drop in lipoprotein A. Wow. But what we've seen is the ApoB will continue to rise, though. So, and as they progress with low carb, as they intermittent fast, their ApoB will continue to go up. And we're in this tough place where what do we tell them to do? And many people coming to me are averse to pharmacotherapy. Sure. So you have a 0 score, you look at their CIMT, it looks great, their physique looks excellent, and they have this nominally elevated ApoB that's
I don't know,
to be increasing. And so we run into this conundrum of what to do. It's sort of a blind spot, I think.
I agree.
And if you give them a little bit of carbs, most of the time, we have found some people are hyperabsorbers. So we've done a cholesterol balance test, and we see that, and some people respond to high dose fiber, right? But very infrequently, maybe like 15% will respond to that. But almost uniformly, increasing the carbs resolves this particular phenomenon. So we're trying to navigate this under the sort of rubric of evidence-based medicine, and it's been challenging. It's been challenging. I'm curious to hear your thoughts on this conundrum. I'm sure one meal a day, your ApoB's got to be up there.
It is a little bit, yeah.
Yeah.
So, and I said, to hell with it. I'm just going to take a statin because whatever, it's fine. I mean, I'm one of these lucky people that doesn't have any problem with taking a low dose of a statin. I think it's okay. But I mean, that's because I like what Peter Attia said. You want to take the long view. Is you have a calcium score that's 0 or low, and your ApoB is high. Are you going to be alive for 10 years? Sure, that's fine. But if you want to be alive for 30, 40 years, then you really got to think a little harder about getting that ApoB as low as possible. And however you can get it down. I mean, I think people have there's legit, some people can't take statins or have to, but then there are other people that they can. And I can, and they can also combine things. They can do low dose statins, and it can do bempedoic acid, which is way underused, and Zetia, and prescription strength omega-3s, and I mean there's a lot of, and Repatha and so forth, the PCSK5 inhibitors. There's a lot of options. There's so many tools to get the ApoB down for people, and I mean you have to individualize. You have to do what works for the patient. You have to meet people where they are, and don't just tell them what to do. So
yeah, it's challenging, and each of these pharmacotherapies is sort of, has a different adverse events profile.
Exactly.
Different long-term studies, and you try to navigate this. It could be a challenging thing. I appreciate your insights. I did so coming back to lifestyle. I did see a recent article, and I'm curious if you've incoined. This will be the last thing, I promise.
No, it's fine. I'm enjoying this.
Showing that HIT therapy decreases atheroma volume, right?
Really?
So HIT therapy decreases atheroma volume in people who've had a PCI. So small study, randomized, I think it was 40 patients.
Wow.
So should we be doing HIT therapy?
HIT, you mean high intensity
interval training?
Interval training.
Yeah.
I think, I love it. I do it. I think it's great. I think, I was sure. I mean, I haven't read that study, but I'm all for it. I mean, if that really can.
I'll
Yeah,
send it over
send it to
you.
me. I'm fascinated with, I think, it can't all be zone 2, right? I mean, I agree. I mean, there's got to be some level of interval training. And intervals are fun. I mean, I think it's great. So I'm all for it. That's fine.
Got it. Listen, any last parting words before we end our show today?
No, I mean, I've really enjoyed talking to you. You're such an inspiration, and you've been so influential, and
You're
really
inspiration. The mutual feeling is
thank you.
absolutely mutual. When I saw that
Thank you.
100-kilometer race, I was like,
Thank you.
this guy is the real deal. That
Thank
was
you.
inspiring. Yeah.
Thank you. Thank you. I'm happy to come back anytime. Thank you.
Yeah. Quick question. If somebody wanted a low carb friendly cardiologist, and how do they find you?
I'm seeing patients in Eugene, Oregon, through Peace Health is my employer, and I'm happy to see people. And I'm on Twitter, but I'm not going to do personal medical advice for people I can't see. But yeah, you can find. I'm on Twitter, and I see patients.
So it's Peace Health, and they can call Peace Health and say, "I want to see David Saenger."
Yeah, I'm online. Sure, you can find me. I'm happy to see anybody. Sure.
Awesome. I appreciate you coming on.
Thank you.